Hi, my name is Shaji Kumar. I am a consultant in hematology at Mayo Clinic in Rochester, Minnesota. At the ASH 2020 virtual meeting, we presented data from the phase 1/2 trial of a novel CAR T-cell targeting BCMA in patients with relapsed multiple myeloma. In fact, there were two presentations that looked at two different trials using CT053 in the setting of relapsed myeloma, one a trial that was done in China and the trial that we presented. Now, CT053 is an autologous CAR T-cell that incorporates a chimeric antigen receptor, which includes a fully human BCMA-specific single-chain variable fragment. And then it is attached to a CD8 alpha hinge region and a 41BB intracellular domain, and finally a CD3 intracellular signal region. Now, this CAR T is proceeding through clinical trials at this time. It does have a fast manufacturing and turnaround time of approximately 8 to 10 days, which we hope will enable a faster or a shorter interval between the apheresis and the infusion of the CAR T cell in the patient. As you all know, the time from apheresis to the infusion has been a significant problem with the autologous CAR T cell, especially in the setting of relapsed refractory disease where patients often cannot wait that long. So we did a dose escalation study. Overall, 20 patients were enrolled in this trial so far. The patients enrolled have been heavily pretreated with a median of 5 prior lines of therapy. The majority of the patients had one or more high-risk features. Nearly half of the patients were penta-refractory, again, reflecting the heavily pretreated nature of the disease in these patients. The toxicity with the CT053 is consistent with what we have seen with the other CAR T cell. We did see some cytokine release syndrome, predominantly grades 1 and 2. There were no grade 3 or 4 CRS. Again, neurotoxicity was seen only in 3 patients out of this 20, 1 grade 3, 1 grade 1, and 1 grade 2. The CRS duration and the time of onset were very similar to other CAR T cells, with a median time to onset of about 2 days, and they lasted for an average of about 4 days and were easily managed with the tocilizumab and steroids. We did see rapid responses. By 4 weeks, the majority of the patients had cleared their bone marrow plasma cells, in both the dose levels we studied. Again, 14 patients who were studied at the dose level 0 and the 6 patients who were studied at dose level 1. Now, in terms of responses, the paraprotein responses, we saw a significant decrease in the serum monoclonal protein as well as the serum free light chain, and also the soluble serum BCMA levels, which were fairly rapid, with the numbers dropping rapidly over the first month after therapy. The T-cell expansion reached a peak at about 7 to 14 days and persisted on an average of about 6 months after the infusion. In terms of the overall response rate among the 20 patients that we treated, 10 patients had a very good partial response or better out of the 18 patients who were evaluable for response, and the remaining patients had a partial response. The responses have been durable so far. There have been only 3 progressions across the trial. However, the follow-up is short, and the patients are continuing to be accrued now to an expansion phase that is going to be looking at the recommended phase 2 dose of 2.5 to 3 times 10 to the power of 8 CAR T cells per kilogram. So certainly this product appears to be very consistent in terms of the autologous CAR T cell, in terms of both the responses as well as the toxicity that we have seen. And hopefully the shorter manufacturing time will enable us to provide these CAR T product to the patients in a rapid manner.